This conference will now be recorded.
So, yeah, that one's okay. So this was an interesting case. Wait, what? Maybe you can't load it. That's a stupid thing. Anyways, you can see it won't let me load it, but there's this very weird appearance on the chest x-ray here. I actually thought there was going to be a mass here in the right middle lobe and maybe something in the lingula. You can look on the frontal, looks like there's a mass here. Some weird vascular thing going on in the left hilum. Anyway, so there was an old CT, which is very interesting. I've never seen this before. So and I'm sure people here have shown similar cases. I've just never seen this. So anyways, weird looking mediastinum, weird looking left atrium. There's really single pulmonary veins bilaterally, which isn't that weird. Even the posterior single draining, almost common vein isn't that weird. But if you look at the lungs and you look at the branching of the pulmonary arteries, this patient, she's never had surgery, but you can see that there is very abnormal lobar segmentation on bilaterally, that basically she has unilateral single lobar lungs that are basically anatomically the lower lobes. So if you look, there's no right upper lobe bronchus. There's this single bronchus. This would be the superior segment. Then it kind of comes down to your basilar segments. And when I see that on the right, I usually think of a scimitar, but there was no clear anomalous draining veins. There's this little vein here. Looks like it actually drains back into the pulmonary vein. And so it's basically bilateral congenital unilateral single lobes. Have people seen that before?
No, it's like an attempted scimitar.
Right, it's an attempted scimitar bilaterally, but it looks like a TAPVR tried to be, but it's weird. I don't know. So it kind of explains why I was seeing that. I wish I could pull up the chest X-ray. This weird thing that I thought was going to be, because history is asthma. I actually thought it was going to be ABPA on the chest X-ray, like a plugged up bronchus. Let's go back to the chest X-ray real quick, and you could see how we can understand these weird things that are actually the pulmonary veins. Anyways, bizarre case.
So they drained, the pulmonary veins drained to left atrium, right? So it's not really, not partial pulmonary venous
no
drainage.
shunt. Bubble studies were negative. She's had this forever. Like looking at the history, she's never, she has, the history I had was asthma. But yeah, there was no shunt or anything. It's just weird. This is just a case I had today, which kind of nicely highlights the different pathologies. It's just a nice example of this perilobular OP NSIP pattern. This one I would call NSIP because we have studies going back 3 years that shows that this is stable, minimally fibrotic-ish. There's some fibrosis, some traction bronchiectasis, but these cysts have been growing over time, but the fibrosis has been really unchanged. And it's just a nice example of someone with mixed connective tissue disease, kind of showing different pathologies in the same lung. So she underwent a biopsy, and which showed follicular bronchiolitis from the Sjogren's, which she has, which would explain the cysts, and then NSIP from the presumed myositis that she has. I know we can get NSIP with Sjogren's itself, but with this degree of ground glass, I don't know. I think it's more related to her well-documented myositis history. So nothing that dramatic, but just a nice example of someone with mixed connective tissue disease, kind of highlighting two different pathologies. This is another really weird study. Let's see, I'm trying to see which one. This is an outside study. So let's see if this one shows it decently. I hate these thick slices. So, okay, patient has, I'm sorry, that's a PE study, but you can see that there is this very nice sequestration here. Sequestration actually connects to the celiac axis here. So the celiac axis actually supplies the artery. The pulmonary venous drainage is centrally. Here's your little plugged up airway from your lack of communication with the central tracheobronchial tree. And that's fine. That's not that exciting. What's weird is, look at, so she happened to have this is an outside study, she happened to have a dual energy, and I was just looking at it. Someone had asked me to look at this, and you can see that the left lower lobe pulmonary artery is pretty much out after the superior segment. Additionally, the lingula is out, and then the right upper lobe is just gone. She doesn't have a history of PE, and you can see so they were thinking that this may be TB or some infection, which it theoretically could be, but I was wondering if it had developed, and I think it is super infected, but I was wondering if it had developed in an initially infarcted lung. Maybe not, maybe it's just poorly oxygenated lung. But I really couldn't explain very well these, because it doesn't look like standard CTEPH. I mean, standard CTEPH usually see a hint of a vessel. So here you can see a complete lack of perfusion in the area of the scimitar, which isn't that surprising. Not scimitar, the sequestration. Here's the lack of perfusion in the lingula, and then here's the complete lack of perfusion in the right upper lobe. So I'm guessing, and this is a guess because I don't know, that this patient must have had some, I don't know. My theory was some very early in life, either intrauterine or neonatal or very early in life, something that led to occlusion. I don't know if it's a thrombotic occlusion or she had some infection or something that led to these vessels being knocked out. Anyone else have any thoughts about this? Because I really don't know.
No, I'm kind of stumped.
Yeah, there's just no right upper lobe. Anyways, it was, and the most interesting case, which I was happy to get a very nice pathologic proof on the other day. So this is a patient where the patient has these weird, very focal areas of ground glass opacity, and within the ground glass, there's all these little nodules. This ground glass is now more consolidative here, and I think there's another focus, or maybe that was it. But if you look, what was also interesting was that there's these multiple fatty foci in the heart. You can see them here. And this is a younger patient. These are not like the typical balls of fat or like areas of fat you get in an older patient or older women. These are, clearly fatty lesions. You see one subendocardially here. And then if you go down to the kidneys, this doesn't show it on this study, there was some history of a fatty lesion in the kidney. So the patient has a history of TS. Let me go back to the initial study. Let's go back in time. And then you can look at those areas of ground glass and nodularity. And they're there. I'm not doing a good job windowing these. They're there, but you can see they're less consolidative. And the nodularity has grown with each sequential or each subsequent study. So let's go back to 2012. And I had said, I think, even though I don't know, so here it is. Now here it's mostly just ground glass with very little nodularity. Now there are some nodules here, but just given the findings of the fatty things in the heart, ooh, that's not a good look. I just raised the possibility, although I've not seen it look like this, of multifocal multinodular pneumocyte hyperplasia. But it was read out as, and she's like 28 or 30, it was read out as cancer. I don't know if it was here or external, so they biopsied it. And sure enough, this was multifocal. These areas here, both of them were multifocal multinodular pneumocyte hyperplasia. Very focal areas. And I've only seen MMPH like 2 or 3 times, and you get like little nodules like this. You don't get these very focal areas like that. I just have never seen that. And I was curious if anyone else had seen that pattern of MMPH before.
Not like that.
Yeah, well, if you give me a second, I can show you the path. So you can see the let's see here. Can you see the screen with the path on it?
Yeah.
Okay, so these are the biopsies, and again, I don't know, but these are all supposedly type 2 pneumocytes staining for things, and that this is all just MMPH. So I thought that was kind of cool because it kind of fits, but it doesn't look like what it should look like. That's what I got.
All right. I don't know if other people are having audio issues. If
What?
you're not talking mute, that might help with the system. All right. We got Travis, David.
I'll let Travis go first because he's not presented. Jeff, there's a lot of echo on your line.
I know it's coming from Seth. Well, maybe, I don't know. Let me see if I can fix it.
Let me mute sorry, I'll mute my microphone.
There, is it still echoing?
Better.
All right. Travis, you want to go? I can't hear him. David?
I can go. Can you see a junky-looking radiograph?
Yep.
Okay, this is one of our cystic fibrosis patients who was put on Trikafta. This was pre-Trikafta in 2018 or 2019 with lots of junk in mid-lungs and probably some mucus plugs here, these blobs, a little bit of scar. And then this is after the drug. You can see on your left now what this drug has done. It's practically normal. There's a little bit of, you look really hard, you could say there's probably some bronchial wall thickening. And this is CT after. I don't have a before to compare, but after we do see this bronchiectasis and mild bronchial wall thickening.
I still see the chest X-ray. Am I wrong? Is my screen frozen?
Are other people seeing the CT along with the chest X-ray?
No, I just see the radiograph.
Okay, maybe it doesn't like the doubling here. How about a CT? Are you seeing the CT now?
No.
Okay. I don't know what's different now about this from last time.
We still see the radiograph.
Yeah.
Here, try stop sharing, and then there's if you click on the sharing at the bottom, there's pause, and then you can unpause it.
So let's see now. I see at the bottom, I see share.
Yeah, try that. Click on the up arrow, and then there's pause screen sharing. Try pausing it and then unpausing it.
Where is this up arrow?
Next to the share. There's like a little pop-up menu.
Okay. And so let's see, it's got people's name there under. This is control.
No, you must have a different.
Here
Here,
we
let me
go.
just grab control and I'll give it back to you.
Okay.
Okay, try again now. Okay, now we see a radiograph.
Okay. Do you see a different radiograph now?
Yes.
Okay. So this is the original radiograph, and this is your radiograph on with cystic fibrosis. This is your radiograph on Trikafta. Does it look better? Yes.
Yes.
Okay. And here's CT now. I don't have a before CT, but this is CT after Trikafta, and you can see that there is this moderate bronchiectasis in upper lungs. Very little in the way of mucus plugging, just a little bit now, and modest bronchial wall thickening. So, this disease reduction has been phenomenal. It's actually fairly uncommon for me to get examples of cases to show you the effect of Trikafta because people aren't coming in with symptoms that will get them a chest x-ray or much less a CT scan now on this drug. So it's been very powerful in our cystic fibrosis adult population. Okay. Can you see a new radiograph?
Yes.
Okay, so this person has a bad habit with his mental disturbances of pica. He has a schizoaffective disorder and probably autism, and likes to swallow things. So at this point, he'd swallowed this object. He actually swallowed two of these curved, hooked razor blades. So this thing down here in his stomach. This is in an outside hospital. He had this radiograph taken. He's got a lot of consolidation in the bases, particularly the left. He has pneumomediastinum. He's got a big gas collection here, and then he's got gas going up into the neck, endotracheal tube going down the right bronchus slightly. So around that time, he had a CT scan. So this is at the outside hospital. Can you now see CT?
Yes, we can.
Okay, good. And you can see that there's some funky gas collection coming off the back of the trachea here. Here's the esophagus sitting over here. And we do have this pneumomediastinum and gas going up into the neck. So at the outside hospital, they attempted to retrieve the razor blade doing endoscopy. So they got down to the stomach and they hooked one of the razor blades. They were said to have put a sheath over it or something like that, and then they withdrew it, but they lost control of it. They had difficulties in the upper chest, and they when they were pulling this thing out, and they realized that there was now a bigger communication with the esophagus, and they abandoned the procedure and shipped him to Harborview. And then we have a later radiograph that day, again showing the gas collections and the stuff in the neck. And then he had this CT scan later the same day. This is about 18 or 24 hours later, and you can see that now there's this huge, basically, connection here. The trachea and the esophagus are one here in this very dilated space up here. So this was the result of the attempted retrieval of the razor blade. So the treatment at this point was to do a laparotomy, go in and retrieve the foreign bodies, the two razor blades from the stomach, and then a secondary operation was to try to repair this tracheoesophageal fistula. So a very bad result here from swallowing sharp objects here, lacerating things on the way down, and then having complications of attempted retrieval. So I think that was a pretty ambitious thing to try to remove something as big as those razor blades endoscopically and stuff like that. It'd be really hard to get something that big in a safety sheath. Okay, this person has an abnormal chest radiograph. I hope you can see big masses and nodules in this person.
We do.
The reason for this chest radiograph is that this person has rheumatoid arthritis and was going to be put on some immunotherapy for that. So there was they wanted to make sure there wasn't any underlying infection, and lo and behold, these big masses showed up. I think these were kind of unexpected. Um, so here's what they look like on CT. Very firm looking, very well defined, probably showing some vascularity here, some blood vessels within. Um, so, I was thinking if this person's already immune compromised from therapy for inflammatory disease, could this be, cryptococcus? Big masses and stuff like that we've seen with cryptococcus before. If the person's on prednisone or something like that, there's increased risk. Sudhakar thought this might be lymphoma, but I don't like lymphoma because these masses look too firm for lymphoma. Lymphoma usually is not quite this dense and well defined. It tends to sort of smear into the lung more. So I was really, having a hard time figuring out what this could be. It doesn't look like solitary fibrous tumors, although we've seemed to have had an epidemic of those. So we're kind of stuck waiting for a biopsy. What do you guys think?
Well, I mean, it looked like maybe sarcoma metastases. They're so big and well defined.
Yeah,
If they're
yeah,
rheumatoid nodules, usually by the time they get this big, they cavitate because they're necrotic. So that doesn't really seem to fit. I mean, they'd be the biggest rheumatoid nodules, but
Are they just in
yeah.
the upper lobes, just those two, or there? I mean, it'd be weird to have sarcoma. I mean, it could be just
yeah,
upper.
It doesn't. It's not a very good distribution for metastatic sarcoma. You're talking about sarcoma from somewhere else, Jeff?
yeah, I mean, just the size and such.
Yeah, but they're upper lung, which is not the greatest distribution.
Yeah.
And
Right.
then arguing against rheumatoid nodules is the fact that we seem to have neovascularity in it. So, okay, well, they biopsied it, and it turns out to be metastatic melanoma. But in the history that we had at the time, there wasn't even a history of melanoma. So I was trying to get the records this morning, and I was temporarily locked out. So I was trying to get if they went back and got history of an earlier melanoma. But this is melanoma, so it is a metastatic sarcoma, as you predicted. It's just an unusual location. This mid and upper lung predominance here. We expect most Mets to be, as they're bloodborne, to go more down to the bases. So this was melanoma, and that is a sarcoma. So good job. So it's got that sarcoma look, doesn't it? They're very firm looking and pretty
Mhm.
fast growing. These
And
things were
and
not
the
there
size alone, and
in
you can see,
2021.
the big one on the left had a vessel running right into it.
Yeah, yeah.
Yeah, David, I think like lung cancer, you can have melanoma without a primary ever identified. I've seen a couple cases,
Hmm.
but
Yeah.
but not like that. Wow.
Are you saying it's a sarcoma? Is melanoma now considered a sarcoma?
Melanoma was considered a sarcoma when I went to medical school, but that was, when people were still riding around on horses. But um, so correct me if I'm wrong.
I
We
don't.
used
I
to
don't
Yeah, I
know.
mean,
melanoma
neural crest origin cells, so they're different.
That's a good. I should investigate that. Okay,
It's a
so
Yeah.
unexpected result here, and as you'd expect, it's very avid on PET scanning here. These big lesions. So it's really probably metastatic disease, but I'll try to clarify that. And if they're starting to call it a primary, they diagnosed it as metastatic melanoma. So I need to investigate how they arrived at the conclusion that it was metastatic rather than primary. But it's an unusual distribution for metastasis. Okay, one more. So this person had um, something that impairs swallowing, I think. And at this point, this is an older radiograph, had a little patch of consolidation here that subsequently cleared, that is, I think, consistent with aspiration. I don't know what the swallowing difficulty was. And then came back with this radiograph here with a big gas and liquid collection here. And on lateral view, we can see this very big fluid level out here laterally. So it looks like a big empyema with gas in it, implying bronchopleural fistula. And on CT, indeed, it is a extensive, huge empyema with gas collection. This is evidently before there had been any instrumentation, so the gas is there not because of the hand of man, but because of a bronchopleural fistula. And the organism was recovered from this. I don't know whether there's some lung consolidation down here. It's hard to judge, but they did identify an organism, and this is Actinomyces odontolyticus, which is an organism that can cause tooth decay. So it arises around teeth. So this is an Actinomyces bronchopleural fistula with a huge pleural collection. And you can see the liquid part there, and as we come forward, then we get the gas part. This is a kind of shutter effect of the horizon here. Okay, guys.
All right. Well, those were some good cases. That is the biggest actino abscess thing I've ever seen.
Yeah.
All right. Travis, you have cases?
Yeah.
All right.
Let's see if the audio works. It seems to be working better now.
Yeah, I hear you. If everyone stays on mute when they're not talking, it seems to work.
All right. You see my screen?
Yes.
Okay, we're going to start with the most recent and we'll go back. This is just a bizarre look, for lack of a better description. You can see these areas of calcium, either calcification or ossification along the pleura, but it's really interesting how you see this along the, basically along the interstitium, along the bronchovascular bundles, or within the lymphatics. You can see this patient's had a prior sternotomy. They've had a prior wedge resection at least ×1, if not ×2. And you can, as you scroll, you see that there's a few little similar attenuation things really everywhere. Bones. So obviously this looks like widespread metastatic disease. Even in the retroperitoneum, similar look to this kind of fluffy, cloudy stuff. And this has progressed pretty considerably over the last couple of months. This is 6 months ago, and you'll see that they'd had a lobectomy and had a few of these little foci in the pleura, but things have gotten considerably worse. So any guesses to histology of this? Because I had not seen this type of look before with this specific disease.
Is this metastatic osteosarcoma?
Yeah, it is. Yeah, she had a lower extremity femur osteosarc a couple years ago. But yeah, it's just, I mean, I showed a case a couple years ago with the pleural involvement that almost looked like pleural plaques, but it's just this stuff, like right in here, that just is bizarre looking. How it's just
It almost
growing.
looks like
Yeah.
endovascular metastases.
Oh, but it doesn't look like it's narrowing them though, right? It's almost like it's growing along and around. Like that's why I was thinking it's more like in the interstitium along the vessels.
I see what you mean, yeah.
Yeah. But right, so it's like you can see it's just it's just highlighting the walls.
That's
Um,
crazy.
yeah. I mean, unfortunately it's just a sad case because she's got mets everywhere. You can see in the subcutaneous tissues, in retroperitoneal, pelvic nodes, bones everywhere else. But I just had not seen this type of morphology before. So I'm curious if any of you have, but I definitely had not. Um, yeah, yeah, this is just a nice radiograph. You can see the cervical collar. It's a young patient, uh, comminuted left humerus fracture. It's interesting. I was reading the chart. It said she was a level 3 trauma, restrained passenger MVC from a rear ending. I mean, I don't know how all of these ribs in her humerus were fractured unless she really just like was thrown into the side or the dashboard or something. But just this, you know, big cystic space up here is a big, one of the bigger lacerations I've ever seen in the lung with surrounding hemorrhage and contusion and spontaneous pneumothorax. And this did improve over time. The one question was, could this be something pre-existing that she happened to have? If it was a 70-year-old, would you wonder if they had a cystic adenocarcinoma and then just happened to have trauma? Sure, maybe, but not in this case. This was just a laceration, but I thought it was just a textbook example. So not too exciting, but quite an impressive image showing that. So you can kind of see the correlate for the radiograph right there. That's about as big of a laceration as I've seen from non-penetrating trauma.
You almost wonder if it was like a couple of them that just were right near each other and they coalesced.
Yeah.
You know, I wonder if the distribution of that thing, that location in that area reflects wearing a diagonal, shoulder strap seatbelt, coming across the chest there. That would,
Yeah, and the passenger, excuse me, she's passenger. It would have been her right shoulder that was strapped in,
is that
unless it
right?
just threw her left arm forward and her left side of her body hit the wall or the dashboard or something.
Okay, so the strap comes from the outside of the car toward the center of the car. Is that it?
Yeah,
As it goes
yeah,
down?
and she's the passenger, right?
Okay.
Yeah. Huh.
Unless she was a passenger on the left of the back seat.
Yeah, that's true. Okay. Curious if you guys have ever recognized this before because it's apparently more common than I've ever given it credit for. But this is a lung cancer screener that I was reading last week, and I noticed this and I noticed this little band of muscle, and I just thought, huh, that's funny. Especially on the left, it clearly looks like it's going from the pec to the lat right there, and it's a pretty sizable muscle in this case. I showed this to a few of our MSK folks. They just agreed that they said it was they didn't know if there was a name for it and said, looks funny, but probably just some accessory muscle. Anybody know what this is called? Because
I
it
can't
does
see
have,
where you're pointing, Travis. Can you point again?
oh, right here. I'll zoom in on the left side. So this muscle right here, this thing right here,
Yeah.
it goes from the pec, so it inserts right there, goes down into the axilla, through the axilla, anterior to the axillary vessels and whatnot, and then inserts on the lat right there. And apparently, it's commonly encountered in axillary surgery and is important when they're doing axillary lymph node dissections, but I didn't know this had a name and had never seen one quite like this. So, anybody?
Nope.
Well, we all learned something. This is the Langer's accessory axillary arch. So, and this is a picture of it can be a tendon or it can be muscle fibers. Right here, you see this arrow here in surgery. And as it says here, it's just an anatomical variation encountered in the axilla. Uh, and it's a muscle bundle that originates from the lat, traverses the axilla, and then merges with the pec major, just like this does. And I've seen a few in the literature pictures, like even patients that have large ones, you can see it on just a physical exam if they raise their arm, and it's enough to deform the skin. But that's Langer's arch. So new one for me. But I just thought I was looking at it, I was like, huh, I've never noticed that before. And I
I
haven't noticed
want.
it since,
Yeah,
but we'll
I'm gonna
see.
have to look. I guess maybe you lucked out that it was there and the patient had pretty sizable muscle mass
Yeah,
because it's probably just a little band that probably looks like fascia in most people.
yeah, right. But I've looked and it's crazy because some of the reports were like even double digits of axillary lymph node dissections they encounter this. But I bet it's got to be some sort of tiny little fibrous cord or band. Maybe more like it is on the right side here, but that left one is huge. So, all right, well, we're all in the same boat then, not knowing what that is. All right, where's that other one? I've got one other lung cancer screener that I wanted to show, if I can find it here. Let me see, which one is it? Give me 1 second here. I'm going to stop sharing for 1 sec. See if I can find it.
So if you've ever questioned the utility of this conference, now that we've encountered Langer's axillary arch, it's well established. This conference is
That's right.
so important. Where would we be?
I credit one of my co-residents who's an MSK guy in Texas that I just sent him a video of this. I was like, "Do you have any idea what that is?" And he didn't at the time, but he looked it up and he's like, "I think this is Langer's arch." So, and that it perfectly fits. Okay, so here's a fun management question. What do you do? This is a lung cancer, or what do you call this? This is a lung cancer screener I saw a week ago, and they have a small effusion on the right side, and I saw this and said, I'm 99% sure that looks like a small little pulmonary infarct in a lung cancer screener. You know, it's got the little peripheral rind and the central ground glass, so the reverse halo look, and it's got the ipsilateral effusion. It's all new from a couple of years ago when they had their last CT. So, I mean, I called up the coordinator and told her, and she called the patient. But I'm curious what people would give this in terms of a lung cancer score or
A
lung rads.
0,
Yeah,
either a 0
that's-
or like a 1 or a 2S, but I would go with a 0 because
yeah,
there's too much. Yeah, but
yeah.
I would just call that an infarct.
Yep, and no surprise, they actually did go to the ED, and there's the big PE right there the next day, going down to that posterior basal segment. There's a nice, again, illustration of that infarct. The effusion's maybe
You have
gotten
the
a smidge smaller.
and you have the nice enhancing atelectasis next to it for contrast, which is kind of
Yeah,
cool.
and then
Another
there's additional emboli in the left upper lobe. But yeah, you're right. This you've got the atelectatic lung, presumably they're splinting a little, and then you've got the infarct right there. So,
Did the patient have
yeah, zero.
symptoms?
Yeah, I don't know. You know, they had been seen in lung cancer screening clinic and got their CT, and or I don't know, maybe she was seen in clinic right after the scan or something, but it wasn't apparent that she had symptoms. I mean, there weren't enough to send her to the ER, but she must have had some symptoms, and then the coordinator, you know, because I told her, I was like, this is an infarct, and they sent her to the ED to get this study. So that was kind of a fun one. So all right, well, that's all I've got for now.
Great. Okay, I can show some. Let's see here. Okay, so you should be able to see my screen. So let me show this first case. So this is a good resident case. That's not the right one. They're out of order. Let's see. Nope. Nope. Yeah, here we go. So this is a 30, I want to say 7 or so year old male who presented with some chest pain. And I only have a frontal view, of course, but you can see there's this large mass here. It's got a smooth interface. It obscures the right heart border. There may be a pleural problem here, but you can see within it there are these calcifications. So suggesting some kind of mass. It's pushing the heart to the left. So mediastinal mass. See that it's probably in the prevascular anterior space, but it's really big. So the usual song and dance differential, but the calcifications would make lymphoma unlikely. So you might think of a thymic tumor given his age. He's a little on the older side for germ cell tumor or a giant ectopic thyroid. But he got a chest CT. Let's see if he's got a Langer's arch here. He's a pretty muscular guy. Don't see it, but you can see this pretty classic giant teratomatous germ cell tumor. What's interesting about this case, besides it's big and apparently he's been, quote, self-managing it for a while, is what's going on with the middle lobe. So it's pushed the middle lobe back, and you can see the lower lobe is down here, and it's mostly atelectatic, but the middle lobe looks like it's kind of socked in, and there's almost fat density in some of these airways. And I'm a little worried. I don't know if this thing has ruptured into it or if it's invaded it or what's going on with it. Clearly the middle lobe looks very unhappy, or if it's just, an obstructive infection, something like that. But I was talking to the surgeon, and so what they're going to do for this one is actually do a clamshell thoracotomy to get this thing out, because when they do a vertical sternotomy to get it's with all the spreading, it's harder with the heart. So by opening it up, they'll have a lot of room to pull this out and protect the heart and stuff. And I think he's going to take the middle lobe with it because it's so stuck down there. But this is the biggest teratoma I've ever seen, but it's got fat, soft tissue, a bunch of calcium in there, probably some teeth and bone stuff growing in it, but kind of a cool case. All right. This is an interesting case. So this is a 63 or 4-year-old. Let me get these in the right order. So this patient, the first images, unfortunately, from the outside, and they burned all the PHI into it, so I can't save them. I'll have to work with them, see if I can scrub it. But this patient has this pretty bad pneumonia in the right upper lobe. And then also, you can see in the mediastinum here, there's this abnormal collection behind the esophagus, and you can see there's some cervical spine hardware. So on the outside, they thought this was a esophageal cancer that had fistulized, ruptured in the mediastinum and right upper lobe, led to this infection. They did a bunch of biopsies, but nothing ever came back positive for cancer. So eventually, the patient got treated for the pneumonia, was getting a little better, but you can. Did I pull the right one? Let me go back here. Anyway, got treated for the pneumonia. They put a stent in across the esophagus, and now you can see a very well-formed collection behind the esophagus. So the stent nicely delineates that, but it does go up against here. This is barium from a previous esophagram, this stent stuff, but you can see there's this heterogeneous collection just below that C7 plate. The pneumonia is getting better. And then finally, the patient gets sent over here for us. Let's get the right CT. And this is the most recent CT, and the stent's out, and you can see this really nicely well-formed abscess behind it. And the esophagus itself actually looks pretty good. There's a little bit of fluid in it. And the patient had been getting antibiotics. But what's really kind of cool is the fluoro. And what you can see here is, so here's the esophagus, and there's this little, let me see if I can make it bigger. Right here, we can see barium coming out and running along this cervical spine plate and then dipping in behind here. So what's happened is this plate has eroded into there's a fistula between the esophagus and this plate, which is now infected. So it's unclear where it started. The thought is whether it was just trauma or something like swallowing or something that led to a tear, but got infected and seeded the lung. So that what they're going to try to do is go in there, remove this hardware, and clean all this out. But it's apparently, when I was talking to the surgeon, it's a very difficult surgery. It's a hard place to get to. They're going to have to divide the trachea and the esophagus just to move stuff out of the way and clean all this out. And then it would be probably a multi-specialty surgery. Would come in and clear all the spinal stuff out. And then probably have to put a tissue flap in there. And then they can do primary anastomosis of the airway and the esophagus, but not a pretty thing, but not cancer. But I've not seen I've not seen a plate like this erode into the esophagus before.
So Jeff, you think that it was just the presence of the plate, or do you think that there was some, weird thing with swallowing that tore the esophagus, or what?
That's what I don't think anybody really knows. I mean, you can see this patient has had 2 multi-level fusions, so they don't move their neck much. And the fusion looks good. I mean, typically, the esophagus is fairly mobile there, so you would think there's not unless there was some inflammation that it got fixed, that it would erode through. There's no signs of osteomyelitis. That, did the patient swallow some food that caused like a micro tear, like a chip or something, or a bone? I don't know. It's unclear from the history exactly what happened, but I would think we see these plates all the time. I'd think more likely it started in the esophagus, created that little fistula, and it just, because it wasn't because there was a foreign body there, it was more prone to, it was able to just get out of control and get in the lung, but I don't know.
Okay.
All righty. Let's see. Which case is this? Oh yeah, this is kind of fascinating. So I've not seen this before, and I showed it to one of our abdominal imagers, and he had not seen it either. So this lady has bad cirrhosis, portal venous hypertension, and there's this interesting vessel coming off the liver here that goes anteriorly towards across the diaphragm, and then actually comes into the prevascular mediastinal fat, and then joins the internal thoracic or internal mammary vein here. So going all the way up to the vena cava here. So this is a shunt, transdiaphragmatic shunt, but we've seen a bunch of, we see varices and all that, but I've not seen one coming off the liver and going across the diaphragm like this. I don't know if anyone's ever seen this before. Just an interesting pathway that opened up.
I've never seen one that big. I recall seeing some dilated lower internal mammary veins from
Right.
varices, but not like that.
Yeah, there. Let's see if I can get the right side here. Wrong side. Yeah, there it is. There coming up off the liver. Yeah, it was just kind of an odd one there. So that was kind of fun. All right. This is a tragic case. This is a young person who was in a motorcycle crash, and you can see from the radiograph there's already a bunch of support devices, and there's this defect down here in the chest wall. There's some covering here, and you see a bunch of lucency and a bunch of debris that's either in or on the chest. But CT was done shortly thereafter, and this is one of the worst chest wall traumas I've seen. So we've got a couple things. We've got this hemothorax. We've got some bleeding right along the chest drain right here. You can see some blood. But what's crazy is there's just this open defect. There's like a chunk of the chest wall is missing, and you can see there's just lung hanging out under this dressing. It was, a high-speed motorcycle crash. I was apparently not wearing the usual protective gear, so a lot of this is just like the skin and bone were ripped off, and the lung herniated, opened up the mediastinum and the pericardium all into this one space. And then, of course, was massive aspiration and stuff. He had a bunch of other serious injuries, but I've never seen this degree. I mean, I've seen fractures, crush injuries, but never just like a chunk of the chest wall missing unless it was done surgically with a lung hernia. So really bad trauma there.
Did he make it?
All right. We did the teratoma. Okay, I'm curious if any of you seen this. I did find some case reports. So this is a woman who walked into an outside ED, not feeling well, and then proceeded to collapse and code in the ED. She received cardiopulmonary resuscitation and was circulation came back, and was then subsequently transferred to our hospital for critical care. And you can see there's a ton of fractures, and we see this not that uncommonly. I mean, most of the time they do break the ribs now, and they often will get CTs afterwards. Usually they're looking for causes of their collapse. And you see she has a little PE down here, but one of my residents astutely picked up this thing right here. And I mean, it looks all the world like an intimal injury to the aorta. She had no trauma prior to CPR, so this is presumably related to that. And I did find some case reports of it. And there's been case reports of some other vascular injuries, but I've never seen one. Clearly there was enough force, at least to break all the ribs, but usually this is a rapid deceleration injury. So I tried to figure out if they used one of those Lucas devices or not, because those can generate a ton of force. Yeah, if you look up blunt aortic injury and cardiopulmonary resuscitation, you will find some reports, and then there's some review articles that occasionally mention it. But have any of you ever seen this before? I'm guessing no. So that was a very unusual case. So not what you're expecting to see. Yes, and could be easily missed because there is PE and there's fracture and all the other distractors. But yeah, so it's small enough nobody's going to do anything with it. They may get a follow-up at some point. I haven't seen it, so I'm guessing they're going to do nothing. And that would fit along the lines with other blunt aortic injuries. If it's minimal like this, the guidelines say really don't do anything. I think our vascular surgeons usually get a follow-up in 48 hours, and it's almost always gone or smaller. So, all right, I think that is it. So thanks for the great cases, and I will talk to you all next week.
Thanks, everyone.
Bye.
Bye-bye.